We're good to go. All right. My name is Debbie Kornman. I'm the Associate Director of InCHIP, the Institute for Collaboration on Health Intervention and Policy, and I want to welcome you to InCHIP's series of panel discussions on COVID-19. This is the second in the series, and it's focused on messaging and communication during the COVID-19 pandemic. Our third panel discussion is going to happen next week on October 29th at 12:30, and it will consist of 5 presentations on the impact of COVID on vulnerable and at-risk populations. And then our final panel presentation for this year will take place on November 12th at 12:30 with 3 presentations about the effects of COVID on child caregivers. I encourage you to register for either or both of them. Just to provide you briefly some background, last spring we invited researchers to submit proposals for rapid release funds for COVID-focused pilot projects. And we ended up funding 20 very diverse and innovative projects. And these panel discussions are an opportunity for all of you to hear about the preliminary findings from these studies. We're very excited about the work that's being done by our faculty and graduate students and staff. Today there's going to be 4 presentations followed by a Q&A period, discussion period. We ask all of you to remain muted throughout the presentations. We're going to hold all questions until the Q&A period, none directly after presentation. You can wait to ask them then, or you can enter them into the chat. So I'm going to get started because I want to hear about the findings. We're going to start with Marcy Boynton. She's an assistant professor of medicine at UNC School of Medicine. She got her PhD at UConn. Very proud of her. She, along with Howard Tennant of Public Health Sciences, serve as co-PIs for this project. Her presentation is entitled Persuasion and Messaging in the Age of COVID-19, an experimental study of U.S. adults identifying effective messaging strategies for infection prevention behaviors. I'll leave it to you, Marcy.
Thank you. Thank you for that wonderful introduction. It's really wonderful to be back and seeing so many friendly faces for my graduate school days and also my postdocing days, which is when I was working with Howard. And so we've continued our collaboration and collaborated on this project, along with a couple other colleagues who are introduced at the end here. So as everyone knows, it goes without saying, both globally and in the US, COVID has had a profound impact on people's health, on morbidity and mortality. We're currently looking at over 220,000 deaths in the US, and we substantially overrepresent the number of deaths globally from COVID-19. So this is a very fast evolving pandemic. Our lives looked very different beginning of 2020. And early on, when awareness of this disease became more widespread globally in the US, messaging was really scattershot and all over, and not what we know now or advise now. So World Health Organization and also public figures in the US were saying, it's not a big deal, or it's just as bad as the flu, or please don't wear masks, and we now know it's quite different. So that sort of doesn't help in terms of public confidence in people who are messaging to them. You may have seen in around March a postcard come in your mail, and it was President Trump's coronavirus guidelines for America. And so it featured his name prominently on one side of the postcard, and on the other side, a set of recommendations for how to prevent the spread. I'd like to point out a few things about this postcard as you think about, as we talk about messaging. So one is you can think about the message framing. Right? So things like slow the spread would be an example of a message frame, or that you're at risk and your activities can increase risk for others. That's another frame. You can also think about the different behaviors that are being advocated. So avoid social gatherings, stay at home, wash your hands. These are all examples of behaviors that we are trying to get people to do. And then finally, message source, right? So we have a couple here being referenced, most prominently President Trump. So since those early days, messaging has evolved. It's largely become more consistent, not universally so, as we all know. And however, more and more there's this advocating for wearing masks, staying apart, having good hygiene, and so on. So we were really interested in understanding messaging and message elements. And so for us, that involved really understanding different phenomena. So one is effectiveness of messages. So the way we measured it in our study was looking at perceived message effectiveness, right? So this is really looking at people's perceptions of how effective a message is. And these perceptions have been associated with actually predicting behavior. And it's been argued that it's a causal antecedent itself of message effectiveness. Another thing to think about as you think about messaging and people's reactions to messaging is really these strong reactions we're seeing in the public against messaging in terms of advocating socially distancing, businesses being closed down temporarily, mask wearing. So you're seeing a lot of both public resistance against these types of behaviors, reactants, and also public figures. So Scott Atlas is a radiologist from Stanford who's been sort of a surrogate for the White House saying, hey, masks don't really work. We've certainly heard other prominent figures, politicians, arguing that they're not really necessary. So sort of bringing these different ideas forward, how can we think about messaging? How can we measure the effects of messages? I sort of decided to brush off my social psychologist roots a bit and use a nested stimuli design. I actually learned about this from David Kenny when I was at UConn. And so this probably, for many of the psychologists here in the audience, this type of set of stimuli looks very familiar, right? So a lot of folks interested in perceptions of race and ethnicity and how bias then can be play a role in how we perceive people. We have these stimuli that vary in terms of, say, nose shape and skin color and eyelids and so on. And so we then have people rate these different stimuli, and that gives us a sense overall of then how these different features in terms of how they vary, how that predicts perceptions. So this general framework has begun to be carried over into the public health sphere and messaging sphere with the idea that you can disentangle essentially different elements of messages like we looked at on that postcard to actually determine which are most effective and which actual elements of the message can potentially be harmful and work against the intention of the message. So in our study, we looked at 4 different components. We looked at message frame, so like that slow the spread frame in the postcard. So here you're seeing a whole list of them. I won't go through them all. We also then advocated for different behaviors: washing your hands, wearing a mask, staying home, staying 6 feet away from others, and avoiding social gatherings. We also varied the type of penalty associated with that message. So do this and there might be no penalty. It might be, or you'll be fined $300, or you'll be arrested. And then finally, source. So president and the CDC, which is what we saw in the postcard, president by himself, CDC by itself, state health department, and local. And so when you combine all the different, have all the different combinations of these elements, we had over 2,500 different unique messages. So I won't get into the details, but doing all the syntax and programming for the analysis was quite a lot of work. I will also say that we didn't have the combination of wash your hands and either be fined or be arrested, because obviously that didn't really make sense from a credibility standpoint. It seems unlikely that would be enforceable, obviously. So what was our actual study design functionally in terms of what people were rating? So each individual, in addition to a set of other measures, they were given 5 separate measures separately to rate. And so they rated these messages on perceived message effectiveness, which we already talked about, and also related to message reactance. So this would just be an example of a set of messages a person might be asked to rate individually. And you can see that they vary substantially, again, in terms of the combinations of the different factors. So for each of these messages, they, like I said, they did a series of ratings. And so for PME, For PME, we used 3 items as messages informative, credible, and persuasive. And for reactants, this message is trying to manipulate me, annoys me, and interferes with my personal. And so who completed our study? This was Qualtrics actually recruited our sample, and it was a national sample of US adults, 934 to be exact. And so this, even though it was not a nationally representative sample in terms of applying sampling weights, it certainly approximated the US population and another number of criteria in terms of gender, age, race. We did have an overrepresentation of Hispanic Latinos in our sample, although we didn't see any association between ethnicity and in our models in terms of that and our outcomes. We still, though, did control for it in our models. So in terms of behaviors, so what did we find? In terms of behaviors, what we found was that compared to hand washing, we found a sort of increasing sort of lessening of effectiveness of a message depending upon the type of behavior. So people were more willing to socially distance at 6 feet apart. Even they saw messages even less effective if they were asked to wear a mask or to not do social gatherings or to stay home. So those messages were seen as less effective. There were also greater reactance for those different behaviors, especially the staying home. That was almost a 1-point difference on a 5-point scale, which is a pretty sizable effect size in terms of people really seeing those messages as less effective and reacting more strongly against them. In terms of penalty and message effectiveness and reactance, what we found was compared to no penalty, people rated messages less effective and had stronger reactance to them if, and I'm sorry, that should actually be a negative next to the 0.4, for both a fine and arrest. And actually, people seem to be more unhappy with the fine than arrest, and I'm not sure exactly what to make of that. It wasn't a large difference between the estimates, but either way, people really were dissuaded, did not find messages effective when they were told there would be a negative legal consequence to not doing the behavior that was being requested. So we looked at a lot of different message frames. So I don't, given the time constraints, I don't want to go into the nitty-gritty. What I will say is that messages that were sort of commanding people to do this, to do the behavior question, messages that reference death, messages that use a humor component. So there have been messages like this, particularly trying to appeal to young people. So there was one out there that was, I believe the framing was mask it or casket. So trying to use these humorous approaches and also Trump as a message source substantially decreased the effectiveness of messages and increased reactance. On the other end of the scale, referencing infection, that you will spread infection or be infected, referencing coronavirus specifically, and also referencing the CDC, state or local health department also improved effectiveness and decreased reactance. And then there were a whole lot of pieces in the middle that either were neutral or had a small negative. So those were results overall, and we recognize that different people have different beliefs about the seriousness of COVID-19. So many people, certainly many, I imagine most of, not all of us here, believe it's a very serious problem. There are a lot of other people who don't believe it's true. So we developed the 6-item COVID beliefs measure that was trying to really get at this question of how serious they believe COVID-19 is. And we had good psychometric properties to this scale. And so what did we find? So these are our results. These are our multi-level model results, our betas. And so it's looking at these different results. These are stratified analyses by whether someone it was trichotomized essentially. So the lowest third who didn't think it was a very serious issue, and then the people in the middle, and then the people in the high end who think COVID's pretty serious. And in terms of message effectiveness, the people who think COVID-19 is very serious, it really didn't matter who the source was. They found the source was really compelling in terms of the message being more persuasive, with the exception of Donald Trump. they actually found the messages in that case that actually negatively impacted effectiveness of messages. Same pattern for those who were sort of in the middle. And then for those who don't think COVID-19 is serious, you didn't really see many elements that increased effectiveness in terms of source, except with respect to the state and local health departments. Citing those organizations as a source seemed to improve the effectiveness of messages. In terms of message reactance, you see a similar sort of pattern where citing a public health organization increased or decreased reactance for those who feel that COVID's a serious issue. Similar pattern, although much more muted for those in the middle. And then for those who don't think it's a very serious issue at all, no sources really decreased reactance, except we did see a little bit of a trend with the state health department. So we published some of our source findings, not as fine-grained as what we just showed you because of the research letter, but we published some of our findings around source in the American Journal of Preventive Medicine in August. So they expedited its publication, so we actually still don't have the full proofs yet. It's just the journal proofs that were released. And so what we found there also, I just wanted to add one more thing, is that we looked to see whether trust in Trump affected people's perceptions of messages as opposed to trust in CDC and trust in state and local health departments. And what we found is for people who don't trust at all, citing him as a source really decreased message effectiveness and increased reactance. But for those who do trust him, including him as a source didn't improve message effectiveness at all, both by himself and also his name paired with CDC. So in short, having Trump's name associated with these prevention messages only hurts their effectiveness. It doesn't help whatsoever. Okay, so in summary, I would say that a consistent fact-based communication from credible sources are really what we should be focusing our messaging on. And in doing so, we can save thousands of lives. And so I just want to wrap up by thanking my colleagues, Howard Tenen, my co-PI, and my co-Is, Joseph Lee and Ross O'Hara, and also InCHIP, who very graciously funded this study. We hope they feel like it was worth the investment. And thank you all for listening.
Thank you, Marcy. We definitely think it was worth the investment. I think those incredibly important findings. I would love to spend time learning more of the details. Look forward to reading your publication. I want to now turn to Sarah Willen, who's an associate professor of anthropology and director of the Human Rights Institute's research program in global health and human rights. She's also the PI for this project. She's going to present on her very innovative pandemic journaling project, Design, Aims, Future Directions. It's all yours, Sarah.
Perfect. Let's see if my sharing works. Can you see my screen? Yep. Okay, terrific. Thank you so much, Debbie. It's wonderful to hear your presentation, Marcy, and I look forward to others as well. I'm going to expect you to give me a signal, Debbie, when I'm getting close, because I also have an inclination to speak quite a lot, and I have lots to say about this project, which is super fun and kind of unusual, I think, for InCHIP, but I'm going to argue in a good way. So the project I'm going to talk about is called the Pandemic Journaling Project, and let's see, I'm going to go into presenter mode there. Great. It's a project that's funded with a seed grant from InCHIP, also with funding from Global Affairs, from the Human Rights Institute, and from over 20 other units at UConn and also at Brown University, where my co-PI, co-founder is located, Katherine Mason. And what I'm going to do today is really walk you through the project and how it works, give you a little bit of a hint of where we're going, since we haven't really had a chance to analyze too much data yet. The way this project is designed, we've tried to create something that will will collect data over a period of time, essentially over the period of the pandemic, that can be analyzed in real time by folks in a variety of disciplines now, and also with a longer time horizon. And I'll talk about how that will work. So here you go. This is the website for our project, the Pandemic Journaling Project. If you want to take a look at it, I have to confess we've got a little bit of a web maintenance problem going on right now, so some of the links aren't working at this particular moment, but I assure you they normally do. So the project is two things. It's essentially a journaling platform and also a multi-methods research study at the same time. It's running completely simultaneously in English and in Spanish. And I just wanted to give a shout out to our terrific advisory board and research team. We have collected brilliant folks from around UConn and Brown and some other universities as well to give us insight on how to think about what researchers in the future might want to know about people's lived experiences during this pandemic. And we've got an advisory board that includes faculty and also students, and that's something that's really important to us. So this is a quick little graphic that Global Affairs actually put together for us to give you a quick window onto what it is we're up to and how we're doing. So far we've got over 550 people around the world who've been contributing to the journaling project. It's actually 24 countries. I'm teaching some qualitative students about data cleaning. So that's, but we do have, I have verified, over 4,000 individual entries so far. Of our participants, the majority are participating in English, but we've got a nice chunk in Spanish as well, the largest group in Mexico. In terms of race ethnicity, you can get a quick window. About 50% white, 11% Hispanic or Latino, 9% Black, 7% Asian or Pacific Islander, and 13% mixed race or other. And I will say we're working very hard now to work on bringing more Black, Indigenous, people of color into this project for all the reasons you can imagine, and some others I can talk about. Here's a quick map, again, before data cleaning. We don't have anyone in Afghanistan, unfortunately. Maybe we will at some point, but we're really excited that this is including folks from all over the world. Essentially, where did this idea come from? Some of you might know the historian Dick Brown, distinguished university professor here at UConn, emeritus now, who wrote an email to a bunch of colleagues in March and essentially said this. He said, "We're not often consciously thrust into history. Now we are. It's an opportunity to learn about ourselves and our society, and afterwards it will be an occasion to assess later myth-making and conventional wisdom about the pandemic." I'm a medical anthropologist. I read this and thought, yes, we should be documenting what's happening now. We should create a space for people to record their lived experiences. And we should also get some data on health. So what we've designed works like this. Folks join by completing a baseline survey that we put together with input from lots of folks on that advisory board that you saw a moment ago, including some wonderful folks at InCHIP. After folks complete the baseline survey, they're invited to respond to 2 journaling prompts each week. The first is the same from week to week. How's the pandemic affecting your life? And the second is on a rotating series of topics. So we'll ask about impact on work, impact on relationships, impact on political views, views on how the pandemic is being managed, all sorts of topics. And people are given a space in which they can contribute in writing, by uploading audio, or by uploading a photograph and commenting on that photograph, either in audio or in writing. So there's a lot of flexibility. We're giving people, really space to think about how they want to record their experiences. And the really cool thing is they can download that full compendium of entries at any time. And it goes into a research archive. And they have the choice of deciding whether they want any individual entry to be public or not made public. If it's indicated that they want it to be public, it won't automatically go up. We screen and we curate a featured entries page. And I'm going to share some content for you in a moment. So here are the different pieces of the project. There's the My Journal site where folks can log in and securely download their own journal. There's the featured entries page, which has this curated rotating selection of entries, and everything is shared anonymously. All contributions are fully anonymous, and we wouldn't share anything without consent, and we don't share anything with names or faces or anything like that. The way it's designed, folks contribute now. Anyone who's on our IRB can analyze the data. We've really designed this not just for the two of us to analyze, but for any researcher who's interested and who's kind of come to us with a legitimate research interest to be able to analyze the material coming in. And then we're going to, once data collection is complete, we'll put everything over in the qualitative data repository at Syracuse, and it'll stay there for a good length of time. And then in 25 years, it'll become publicly accessible. So we really are planning this for the long haul. And again, the data included we've got baseline data, we've got the qualitative journal entries, and then we're also asking periodic survey questions. So biweekly mental health data. I can't remember how often, I think every 4 weeks or 6 weeks, we ask about COVID exposure, and then some other questions about political views of government, and government responsibility for healthcare and stuff like that. So it really is mixed methods data set that's growing from week to week. I've given you a quick sense of how many folks are participating. In terms of birth cohort, it's kind of interesting to see. Yes, it's mostly younger folks, but we have some older folks as well. So we've got kind of a lot of students, fair number of retirees, and then lots of folks in the middle. So this is kind of neat. This is just showing our U.S. participants, and I will say this is a month old, so we'd have more data points if I were to pull this now. But we're pulling from all over the country, and that's pretty neat. I wanted to tell you a little bit about how we're drawing people in. Certainly, we've got a fair number of folks in New England, since we've got good connections here in Connecticut and also Rhode Island and Massachusetts. But we've got IRB to give us permission to do some recruiting through social media. So the site, the project is on Facebook, Twitter, and Instagram. And we put out messages like these, inviting either people in general to think about why it would be valuable to have a record of this time for themselves, and also pitching to educators. So we do have faculty at least, by current count, 9 institutions teaching with the project in various ways. And we have an educator resource page for anyone who might be interested in teaching with it themselves. These are the kinds of things that we use in trying to draw people in. And we also share quotes from advisory board members. I wanted to include someone who might be familiar to some of you, our own colleague, Deb Skosh, who's an advisory board member. And so we're trying different ways of showing people the value of creating a record that's both for them and that can have legs and can become something of historical value. In terms of deliverables so far, 2 students and I wrote a piece that's essentially a recruitment pitch, but it's, there's some content in there too, for an online magazine about how one way to kind of decolonize future histories of COVID-19 is to make sure people of color are recording their stories now. So I wrote this with an undergraduate student who herself is Black and an MPH student who is Asian American, and they really led the way. And we made this pitch, and it was published a couple weeks ago. We do have our first peer-reviewed paper coming out, which interestingly enough is for a Judaic Studies journal, because they came to us. They were doing a special issue on the epidemic, or on the pandemic and epidemics historically. And we had enough people who identified in the demographic survey as Jewish that we were able to take a quick look and get some insights onto this, how this particular group is narrating their experiences right now. Just to give you a couple of quick windows, here's a photo and quote that someone shared in one of their journal entries. I think this is another really interesting one. A woman whose father passed away wrote for a series of weeks about the experience of losing her father and mourning her father and burying her father. So, here she shared some photos, some of which she would have shared publicly, but we wouldn't because they included faces. But here, she writes about how they couldn't have a normal funeral, how they tested the Zoom bandwidth at her mother's grave. They had to be socially distant, what it was like at the funeral, and what it's been like to try and mourn and get support from people in this, this moment. And she writes at one point, I think this is so compelling, about how it wasn't a COVID death, but we had to follow COVID rules. Anyway, I just wanted to give you a quick, this is one of my favorites, Arnold the plant and Kenny the diplodocus. This person writes about how watering her plants has really been a source of meaning and, kind of helping her keep the ground solid under her feet. One of the things we learned very quickly was that people weren't just going to write about the pandemic. There's a lot happening right now. So we do invite people to talk about experiences of racism, to talk, we do it in a delicate way because our questions have to last over time. It's a cohort model. So, people who entered in June are going to be answering different questions now. We've got folks entering now, and those questions have to last. So we don't ask about specific historical events, but we do ask questions that invite people to reflect on historical events. And obviously people from the West Coast have been writing about the wildfires and what that's been like. People write about things they do to keep busy, things that make them happy. And sometimes they share really lovely photographs too. So I would just invite anyone who's interested to take a look at the site, check it out, think about teaching with it if you're interested. And this is sort of the key take home for all of you. Data, I've given you the broad brushstrokes, but we really genuinely do invite folks to be part of the project. There is so much more than the two of us could possibly analyze. So we would love to have collaborators. We've already got a couple of grant proposals under review right now. Basically what we've done in terms of designing our IRB is we've got permission to follow up and invite interviews. So we're thinking of designs where we've got folks journaling for 4 weeks. And then so for instance, first generation college students and a parent journal for 4 weeks, interviews with the parent and the student, interviews with them together. In this design, we've got them doing StoryCorps style interviews with each other, and then having a focus group with photographs and getting folks to talk. So anyway, lots of ideas. Debbie, I don't think others can hear you. Oh, now I can hear you.
Yeah, sorry. I think you muted accidentally at the end or something, but we heard the vast majority of it. No, that was really fascinating, incredibly innovative project. You're collecting a wealth of information. So congratulations on that project. It's amazing. Our next presenter is Christine Gilbert. She's a doctoral student in communication. She's a co-investigator on this project with Professor Ken Lachlan, Associate Professor Stifano from Communication, who are serving as the co-PIs. She will be presenting on examining attributions of blame associated with the COVID-19 pandemic in the state of Connecticut. Christine, I hand it to you.
All right, awesome. So really excited to be here today. The research we've already seen from Sarah and Marcy has been really interesting. And so it really is an honor to be on this panel with you all. And obviously I want to extend my gratitude for InCHIP for funding this project. It's been a really exciting experience as a graduate student, kind of getting my feet wet in grant funding. And so this has been a really wonderful opportunity. So I just want to reiterate my appreciation for that funding. So the origin of this project really came out of some work that I was doing in some of my grad classes, looking at kind of spoiler alert, I'm really interested in crisis and risk communication. And so I was looking at, in 2019, there was the largest outbreak of measles in the United States since the CDC declared it an eradicated disease in 2001. And I think we're all likely familiar with some of the issues related to vaccination of childhood illnesses in particular. And one of the things that I was really interested in is in understanding who are people, the general public, who are people blaming for this type of outbreak? Are they blaming the parents? Are they blaming social media? Are they blaming media for kind of the reality that we exist in? And so I've done some preliminary work about measles that I'm happy to talk about, and then COVID-19 happened, and it seemed like a kind of a logical extension to understand this really complex world that we're living in, where we're getting information from the news, we're getting information from local politicians as well as federal politicians, we're getting information from interpersonal sources. And so we wanted to take a look to see and make sense of, how are people attributing blame? And then ultimately, what are the implications of that? And so there's some literature out there, primarily drawing from the crisis and emergency risk communication model, which is a stage model that suggests during certain times of crises, you should be implementing certain communication practices and certain outreach practices. And so in this model, which really informed kind of the structure of the study, stage 4, which is post-crisis, is typically where we're looking at blame. They were using it as a way to make sense of the crisis and as a way to make sense of moving forward. So if we can understand who people blame for some type of outbreak or some type of, this has also been used for natural disasters, things like hurricanes and wildfires, perhaps we will be better adapt in the future to mitigating these risks and these issues. And so in their study, Reynolds and Seeger in 2005 looked at a West Nile virus outbreak that happened in the US, and they found that through media coverage analysis as well as interviews that people were really blaming public health officials and local governments. And then there's also been more extensive work done for kind of longer term public health issues, primarily here in Australia, where they identified, again, doing another content analysis, looking at these 5 primary frames that seem to pop up in the media coverage about who is to blame for the low vaccination rates for children. And so it's Australia as a nation, something cultural. It's the federal government, so something in the structure. It's health providers, it's parents, and it's the anti-vaccination lobby. So there's a fair amount of literature out there about the different groups and areas that are being blamed. And so our first research question was really, straightforward. What groups are people blaming, if any, for the COVID-19 outbreak? And then there's also, I would say, probably, for COVID-19, particularly meaningful, there's a lot of work in instances of public health outbreaks where people tend, as a way to reduce their uncertainty about something, so it's a cognitive process, they tend to blame others. And for a lot of these citations that you see listed here, they're related to the SARS epidemic that happened in, I think, 2005. And so they were looking primarily in New York City, looking at the Asian American community there and the types of racism and xenophobia that they were experiencing. But it's not just restricted to ethnicity or racial classes. There's also blaming others, so immigrants or people who are different, or you perceive them to be different political class. And so we came up with 2 hypotheses here. And so you'll see those who perceive the outbreak as more severe will attribute more blame, thinking, if I find this outbreak to be really intense, I want to make sure that I am trying to reduce my uncertainty as much as possible. So, having blame go to certain areas is a way to control my anxiety. And then also that there will be a positive relationship between score on xenophobia scale and attributions of blame towards Asians. And then we were also interested, does xenophobia overall predict attributions of blame that aren't just focused on a racial or ethnic category? This work was also really informed, I think, in the literature for crisis and risk, a lot of the really early stuff was really focused only on cognitive processing of risks and crises and disasters. But in reality, we're starting to see that, no, emotions play a really significant role in the ways that we're processing information, in the behaviors that we're actually enacting and that we're doing. And so some of the information that, spoiler alert, my advisor is also working on, Dr. Ken Lachlan, is starting to look at this relationship between information seeking and rumination. So in situations like a hurricane or here COVID-19, at what point does additional information no longer serve a good purpose? At what point are you obsessing about information and starting to have these really negative psychological outcomes like depression and anxiety? And so we knew that emotion was likely going to play a factor, but we weren't quite sure how. And then we also there's some literature out there to suggest that how people use social media during natural disasters and public outbreaks is also actually it's an emotional release for them. So they're sharing stories as well as information. So we wanted to look at primary news source predicting attributions of blame as well for how are people seeking information, where are they going, and then what is the experience, what is the relationship between your emotional experience and the attributions of blame. And then last but not least, for the purposes of some of the preliminary results that we have, maybe some of the most important work that we're seeing come out of this data is this idea of political affiliation. So are people processing incoming information through already established frameworks that they, identify as Republican, I identify as a Democrat. And so everything about COVID-19, am I filtering it through these types of frameworks and having these types of emotional responses, even kind of what Marcy was talking about with reactance, right? So am I just reacting because of an existing framework and idea? And so these were all related to political affiliation, predicting attributions of blame, and drawing from previous work, we know that there have been differences identified between political parties in the U.S., between Democrats and Republicans, and flu vaccine adherence, attitudes, and intentions to vaccinate children, as well as actual behaviors. And so that's where hypothesis 3 comes from, is the idea that previous behavior is likely to predict future behavior. But we were interested to see if does flu vaccine, is it a good indicator for COVID-19 vaccine behavior? And then research questions 6 and 7 were, again, about flu vaccine and COVID-19 vaccination behavior as a way to kind of make sense. Obviously hypothetical, given that we don't have a vaccine, but potentially important. So I have a full paper that I am more than happy to share with everyone to go into the nitty-gritties. Needless to say, let me point out some important things here. We were collecting data between April 23rd and May 15th, so really during kind of that first big wave of COVID-19, so people were still experiencing their reactions kind of in a home environment rather than going out. I should say as well, this study was focused exclusively on Connecticut residents. I was really interested in looking at a really particular place where the outbreak in the beginning was quite bad. And so I thought that was an interesting case study. And we ended up, similar to Marcy, we used Qualtrics, and we were able to collect a total N of 510, which is representative of the state of Connecticut in regards to age, ethnicity, socioeconomic status, and gender. And I have those numbers as well to pull. And then important to point out here is political ideology. It was measured on a 100-point scale from liberal to conservative, so we kept it as a scale rather than dichotomizing it. And then all of the measures that we used met sufficient reliability. We also collected a lot of other information that we're hoping to work on kind of more specific papers on with this data, but for the intents and purposes right now, we're just kind of doing a broad brush. The only thing that I want to point out here is, so under measures number 2, you'll see attributions of blame. So we created scales for this. You'll see federal government, Connecticut state government, media, and social media. We did have 2 additional scales that unfortunately the reliability wasn't high enough to use, and that was blaming Asians for the outbreak or blaming other people. So questions like, when I see other people outside without a mask, I get angry and it's their fault that the outbreak is as bad as it is. But for the purposes of the results that I'm going to show you for today, we're just focusing on these 4 categories. So let me move through quickly, but trying to draw out the most important things. So really interesting, first hypothesis, that those who perceive the outbreak as more severe will attribute more blame to all groups. This was not supported at all, which is really interesting, and I have a feeling I potentially know why. You'll see here that it did perceive severity, the more intense I think it is. It positively predicted the federal government blame, but it actually negatively predicted Connecticut government blame, media blame, and social media blame. And we'll talk a little bit about why this potentially is. The positive relationship between score and xenophobia scale and attributions of blame towards Asians. So again, that scale fell apart. So this is really preliminary. It's not supported, but we did see some significant relationships between particular items on the scale, as well as attributions of blame. So there were some problematic things certainly going on, but not reliable enough to support that hypothesis. Positive relationship between current flu shot status and intentions to vaccinate. Perhaps unsurprising, knowing that there tends to be a relationship between intention and behavior. And so we'll see here that flu shot status positively predicted COVID-19 vaccine intentions, and these are all standardized beta weights. And then moving into the research questions, which groups are individuals blaming? Again, we only had those 4 categories. So federal government was most, followed by social media, and Connecticut state government. There were significant, because with the exception of federal government and social media, we're too close to be meaningfully different. I'm trying to think, I'm looking at my clock and I'm realizing I don't have a whole lot of time. So what I think I'd like to do here is, I'm happy to send the slide deck and the paper, but what I'd like to do is kind of move forward here to research question number 5, which I think is really underlining or really kind of defining why we're seeing the results that we're seeing. So when we looked at political affiliation predicting attributions of blame, we saw that political affiliation, remembering that liberals all the way on the left, 0, right, more left-leaning, and conservatives are all the way on the right, more right-leaning. Political affiliation positively predicted Connecticut government blame, right? So those who are more conservative are more likely to blame the Connecticut state government for the magnitude of the outbreak. Also for media blame and social media blame, while political affiliation negatively predicted federal government blame. The more liberal I am, the less likely I am to blame the more likely I am, to blame the federal government. And so ultimately what we're seeing in the data, and again, I want to try and maintain to that 12 minutes, is that unfortunately, despite I think public health officials' best efforts, the COVID-19 outbreak in Connecticut has really been filtered through a political lens. We're seeing this pop up even when we ran a number of post hoc multiple regressions. Political affiliation remains significant despite controlling for any other demographic variable, as well as perceived severity of the outbreak. So conservatives were more likely to blame Connecticut government. We have a Democratic governor here, Ned Lamont. And liberals were more likely to blame the federal government, right? Republican President Donald Trump tends to be kind of the image that we think of when we think of the federal government. And I think part of this is likely also explained by perceived severity. We saw that in our data that if I think the outbreak is more severe, I'm more likely to blame the federal government. So it's not clear if that's political affiliation as much as it potentially might be. If I think it's really severe, I do think the media should be really focused on it. I do want to see my social media followers or people that I follow talking about it. And so it seems to really be, the media is not being, it's interesting. In both studies that I've done related to attributions of blame, despite kind of our anecdotal, how we talk about the media, people generally don't seem to blame the media to that extent. But here it might be related to the political affiliation. And then lastly, more implications related to public health moving forward. We did see that those who tend to receive the COVID-19 vaccine are more likely to blame the federal government. So this suggests that it may be reflective of underlying political beliefs, which would obviously impact how we're doing messaging to people. So if it really is a political split, then we know that the messaging effectiveness is not going to be as relevant, which ties perfectly back to what Marcy was talking about before. Donald Trump's presence, yes or no? So it seems to be really quite consistent. And then maybe a good outcome that I'll end on is past vaccination behavior and beliefs seem to be predictive of future intentions. So those who have received, again, we had 57% of people had received the flu vaccine, which is better than not. And so potentially this may be important on relying on those individuals to take that first step to getting the COVID-19 vaccine eventually. So thank you.
Thank you so much, Christine. Lots of important information there. Wish we had more time to hear some of the detailed data. Hopefully people will follow up with you. Our final presentation is being given by Stacy Brown, who is an associate professor in public health sciences. She is the co-PI on this project along with Tone Ha, who's an associate professor in infectious diseases and microbiology at University of Pittsburgh. The presentation is entitled Assessing the Knowledge, Attitudes, and Resulting Behavior Changes in Response to COVID-19 Among Connecticut Residents. So we're learning a lot about Connecticut residents today. Go ahead, Stacy.
Thank you. I just want to say that all of the presentations have been so varied and interesting and important, that you are all doing such wonderful work and you are tough acts to follow. But thank you to InCHIP for offering funding to support this important research and this venue to share it. I also just want to thank my co-investigators, Tuan Ha, Judy Lewis, Steve Schensel, and then also the numerous community members, students, and faculty who have all contributed to this and subsequent research on the impact of COVID-19. To begin, our overall goals for this project were to collaborate with community-based organizations to reach a wide range of subpopulations in an effort to examine knowledge, attitudes, and behavior adaptations to COVID-19 and the shutdown specifically. And then finally, to identify gaps in these areas and disseminate information with community partners to promote effective outreach and intervention strategies. So I'm going to begin by discussing our methods, which will also kind of give you the background. As we're all well aware, the known number of COVID-19 cases in the United States were very few at the beginning of the year, but by March, COVID cases and deaths increased sharply, and by March 23rd, Governor Lamont issued several executive orders, including the strict Stay Safe and Stay Home initiative, declaring a public health and civil preparedness emergency. So just days before that, before the state shutdown and the subsequent nationwide shutdown, faculty from the Department of Public Health Sciences very quickly got together and developed a survey to assess Connecticut residents' knowledge, attitudes, and their adaptations to this shutdown. because of the need for this rapid response, and because by this time we're primarily working virtually, we decided to get as many faculty and staff and students involved and ask them to use their own social networks to reach out to 3 to 5 people to take the survey as long as they were not family members. So clearly this was not a non-random recruitment process. Then it did impact the results, but it allowed for fast, real-time feedback, and we were able to get 464 responses, which represented the very first week of the shutdown in the state. So the majority of those folks were highly educated and had high socioeconomic status, and we really wanted to have a more representative sample of the state. So we decided to continue this work and at the same time apply for the InCHIP funding. But again, we were already committed to continuing this work. So during the application process, we took the data to the community. Specifically, Dr. Schenzel presented the results to the Community Research Alliance, which is CRA is an alliance of a variety of community-based organizations and university faculty who develop and collaborate on different research projects. And the idea really is to promote community and academic partnerships that are truly equal, that really benefit the community and are not unduly burdened on the community. There's no unduly burden on the community. So as a result of this meeting and then subsequent funding from InCHIP, we collaborated with many of the organizations from the CRA, and we intentionally partnered with a wide breadth of community organizations to improve our chances of reaching a more diverse population. I just want to note that I'm not going to do justice to any of these organizations because of our time limit, but I just want to give a brief synopsis of them. Family Life Education works with low-income families across Greater Hartford. Majority of their families are Latino. The Sudanese American House is located in New Britain, and their mission is to improve the health and social life of recent immigrants with a special focus on immigrants and refugees from who are Arabic-speaking and Muslim. The Greater Hartford Harm Reduction Coalition, they promote the well-being of individuals and communities that are impacted by drug use and offer a variety of services like syringe exchange and naloxone access and so forth. The Connecticut Trans Advocacy Coalition, they are kind of a grassroots organization that works to provide education, political advocacy, and activism to improve the social attitudes and the law to achieve equal rights for trans and gender nonconforming individuals and communities. And the Institute for Community Research, they conduct research and test interventions in on health and public health issues. And their research promotes justice and equity in the state, but also nationally, and they have worked in international settings as well. So we partnered with them specifically on surveying seniors in congregate housing and then also individuals living with HIV. I'm only going to speak about the former today, though. These last 3 that are bolded and italicized, not going to share that data right now, but I think it's important to talk about those partners. So initially, to tap into the Black and Caribbean community, we partnered with Community Health Services, which is a federally qualified health center in the north end of Hartford. And just due to a variety of things, changing responsibilities and living through a pandemic and so forth, it just became a little untenable for us to continue that partnership. They just had so much going on. So then we moved on to work with, they are members of the Community Research Alliance, so we will continue to work with them in other ways. But for this, we asked the Hartford Health Initiative if they were willing to partner, because they also work in the north end of Hartford, and they said yes, are enthusiastic about it. They just started later, so they're actually still in the process of collecting data. So I'm not going to include some of there's no analysis to share with you today. UCED, so I'm sure you're familiar with UCEDs. There are 67 across the country. We're fortunate to have one at UConn. They engage in research and educational trainings and offer technical assistance for with the ultimate goal of improving lives of people with disabilities. We have worked with UCED and will continue to do so, but they also were part of a national project. And so since this is specific to Connecticut residents, I'm not sharing that data. And then finally, Women and Health Together for the Future. So Judy Lewis, Professor Lewis, did this phenomenal thing that in sharing our ideas with this group, Women in Health Together for the Future, which has 22 countries associated with it, and 7 of those countries agreed to administer the survey. So India, Haiti, South Africa, Nigeria, Pakistan, Egypt, and the Philippines. So upwards of 2,000 surveys have already been completed by then. But again, that's international work, so I'm not going to share that. I just really quickly will say that we also partnered with the Hartford Archdiocese to administer a survey in the Vietnamese Catholic community in Hartford. We just didn't get a robust response, but we still analyzed that data. And then also, separately, we shared our survey with medical students who wanted to conduct the survey and add questions to it, to incoming students, for current students, and the recent graduate class. And we had 233 respondents there. So survey development, and we had a set of common questions from that original survey I mentioned that was specific to the first week of the shutdown, and they covered that. Those questions cover demographics and knowledge of COVID-19, trusted sources of information, perceived risk of catching the virus, social and economic impact of the pandemic, and then prevention behaviors and so forth. Each of our partners also had the opportunity to add questions to the survey that were specific to the population. Not every single community organization did so, but some did, and here's just a few examples. So the Connecticut Trans Advocacy Coalition wanted to know more about whether their constituents were still having access to hormonal treatments or scheduled surgeries and so forth during the shutdown. ICR wanted to, they added a loneliness scale for the senior living facilities, and the Greater Hartford Harm Reduction Coalition wanted to know more about service access for their substance users. All of the surveys were finalized and uploaded to Qualtrics. And so survey administration was primarily online, but also on via phone. And so the phone interviews, there was an interviewer who would be entering the responses in real time into Qualtrics. And then it was also multilingual. So it was offered in English and Spanish in writing, and through phone interviews, and also in Arabic through phone interviews or in-person interviews. And then, of course, the Women for Health Together survey, there were other languages as well. So all of the InCHIP funding that we received went to our community partners, and those monies were used to either increase their capacity to administer the survey. So some decided to offer small stipends to individuals to conduct the interviews, and then others chose to use some of the funds to support, to purchase gift cards to incentivize participation. And then the timing, no, sorry, I don't have that up there, but our goal was to have all of the surveys administered and data collected prior to the soft reopening of the state. So mid-April to mid-May was our goal before the phase 1 reopening. We do have a little bit of variation there because some of the organizations just weren't prepared right at the, as early as we'd liked. So we extended that time just a little bit. Analysis and dissemination is happening right now, and the analysis is ongoing. So what we're doing in alignment with participatory action research principles, we are meeting with each of our community partners, virtually, of course, during this time, and presenting the preliminary results. We're discussing implications, thinking about interpretations, and brainstorming next steps. So this slide just represents our variables. We were specifically examining potential predictors of preventive behaviors, and we had 15 items that made up that scale. And here are just highlighted results. So again, these are just the community organizations that I'm, those first ones that I shared with you earlier. So we had a combined N for those 5 organizations of 404, and roughly about half were male and half female, with about 5% identifying as non-binary. It was a range of a vast age range. Compared to our original survey administered the first week of the shutdown, we have a much more racially and ethnically diverse population. And while I don't have it listed here on the slide, the diversity also holds true for the educational background. We do have clearly a financial burden that has taken place. So pre-shutdown employment was about 55%, and 23% of our participants were retired and receiving either state or disability or pension benefits. But of the participants who were working full-time or part-time prior to the shutdown, about half of them were laid off or their jobs were completely discontinued during the shutdown at the time of the survey. Also, just a little bit deeper dive, when we looked at the Sudanese American House participants, of the individuals who did lose their jobs, only 20% were receiving unemployment benefits at the time of the survey. So the financial burden is very significant. And some overall implications. So again, we started with 4 faculty. Well, we started with lots of faculty from the Department of Public Health, but for this project, 4. But then we've expanded that with new faculty, also with leadership from the Institute for Community Research who are participating. And each of us is working with one or more community organizations to share the information. So these are just some overall trends. A high proportion of our participants, thankfully, are reporting that they are consistently engaging in prevention behaviors, like hand washing and wearing their masks and so forth. Again, we're going to analyze this more closely for variability, but that was promising. Across the board, participants scored significantly high on knowledge questions, which included things like, do they know what the symptoms are of COVID? How is the virus spread? When and how to get help if someone suspects exposure or contraction of the virus. And while knowledge was high, I think as Marcy mentioned, information was not necessarily, or I'm sorry, not Marcy, or maybe it was Marcy also, but Christine definitely talked about where information comes from. So the trusted sources were variable, and many of our participants relied more heavily on community organizations and families and friends rather than more formal organizations or the government. And not surprising, but very important, we used depression and psychological distress scales, and overall mental health has been negatively impacted, so across the board. And so some ideas for interventions. We think it's important to facilitate linkages to resources to address these, contributing psychological distress. So certainly employment is one, or unemployment benefits, access to food and other resources. In addition, connecting individuals to mental health supports. Some of our organizations are already thinking about that, considering how to do more of that through offering webinars or in-person support groups, socially distanced in-person support groups. There's also a need for consistent and culturally appropriate, scientifically based information. So trusted sources, again, varied. So being able to, but community organizations are one place where people do tend to trust the information that they receive from there. So getting information that is culturally appropriate, that is appealing, that is easily absorbable from these organizations would certainly benefit the populations. And then related, we need accurate and complete data. So advocating for improved surveillance to monitor and track disparities is crucial. For example, we know that there are factors contributing to the elevated risk of contracting and adverse outcomes of COVID-19 in Black and Brown communities. So we really need improved surveillance to capture data. It's essential to inform decisions and to find around how to best allocate resources. And then finally, we're continuing to collect data, like with the Hartford Health Initiative. We're continuing to analyze data and reviewing mediated variables. We also have a new partnership with the Connecticut Data Collaborative. If you're not familiar with them, they're an organization that specifically provides services to support and empower organizations around doing research and interpreting and so forth. So we actually worked with them, and they submitted a grant to the Robert Wood Johnson Foundation, and they received that grant to continue working with the organizations that I mentioned earlier to build analytic capacity for not only for this survey, but for their research endeavors going forward. So when we do present this information to the individual community organizations, the ones that we have already and the ones we continue to do, one or two of the representatives from CT Data, from the CT Data Collaborative also attend. And they also work with the leadership of those said organizations to not only continue the analysis of the data, but to identify secondary public data to enrich their results, and then also to develop engagement around, training opportunities for continued research. All of this also, I just want to say, is still in collaboration with the Community Research Alliance that I mentioned at the very beginning. And finally, we are pursuing additional funding. We are specifically applying for NIMHD R01. The title is Community Interventions to Address the Consequences of COVID-19 among disparity and vulnerable populations. It's a 5-year grant with multi-level intervention, and we actually we've already had several meetings with our community partners. We've identified folks who want to continue or new partners who want to participate, and we have our next meeting tomorrow morning. So fingers crossed on that. But thank you very much, everyone.
Thank you, Stacy. Very interesting data that you presented. I'm particularly intrigued by the information about people in Connecticut turning towards local community organizations, which, oh, what a cute baby there, which can inform how you actually develop interventions. And my picture has disappeared. Oh, there I am. I want to thank all the presenters. We don't have a lot of time. So much important information. We're not going to be able to process it all now. I want to open this up now for questions. If you have a question, please raise your hand. Click on the little hand symbol next to your name. I'll call on your hand. I'll call on your name, your hand. When I call on you, you can unmute yourself so you can ask directly. While you're thinking about your questions, I have one. So there's a lot of information that you presented. And this is focused on communication and messaging. So how would this inform some type of communication campaign, public health campaign? And I know it's not simple because we're hearing differences based on political party, et cetera, race, perhaps gender. What are some suggestions you have? I'm flickering in my picture. What are some suggestions you have for a communication or public health campaign?
Well, what I would say is just one of the big takeaways that we found was it's important not to politicize public health messaging. And there's a reason historically public health messages were attributed to the CDC and the FDA and WHO because trust in these organizations is incredibly high. We've done other national surveys looking at trust in CDC, trust in FDA, trust in the government in general, and trust in the public health organizations was exceedingly high. And so leveraging that trust to persuade people to enact these very difficult behaviors, that's important. This is an important tool in our toolkit. And so politicizing the situation, I think, does nothing but harm. So for me, that was definitely a big takeaway.
Other comments, suggestions from the presenters or anyone else attending this?
This is Stacy. I would agree. I would just say I apologize. My camera, I had to turn it off because it started flashing and I wasn't sure what that meant. Didn't want to completely disconnect from the session, but I completely agree with what was just said. I would just add, or reiterate what I said earlier in terms of the culturally appropriate messaging. So it's particularly in written materials. So most of these materials are written in the English language, and things change rapidly. So even our over the last since March, since our original shutdown, you notice how quickly advice has changed and so forth. So being able to make sure that changes not only English language materials, but also gets translated into other fact sheets as quickly as possible and pays attention to other cultural cultural background.
So the other aspect I would like also to contribute is that I think it's still wearing mask is protecting us from COVID-19, but still the wearing mask is still very political size, and it's still very hard to persuade other people, especially those living in the like the rural area to wear masks.
Yeah, I think. Go ahead, Sarah.
Oh, I was just going to say, it'll be interesting now or at some future point to take a look at our data set and with some of these questions in mind. So we do ask questions about trust in government, trust in institutions, trust in media, the police, media, corporations, elected officials. So we've got some interesting data. I can't remember what the periodicity is on that. And it's also, we've got lots of folks expressing their views on masks. Who's wearing them, who's not wearing them, where they're wearing them, how they're wearing them, what people do after they're done with them. So there's some interesting qualitative material we've got on these issues as well.
Sarah, I was wondering if that your data will give some sense of whether journaling is helping from a mental health perspective.
That's a terrific question. And we have, we kind of built the plane in flight. So there are some things we're going to be able to speak to, and there are other things that we would be able to speak to more robustly had we designed this thoughtfully and with time, like you usually do when you're designing a study. But we went from kind of 0 to IRB approved and journaling within about 6 to 7 weeks. So with that constraint in mind, I will say that we have biweekly data on mental health status using the PROMIS scale, which was recommended to us by Amy Gorin. And we have questions that ask specifically about health and mental health. Whether we can, we don't have a random sample, so that's already got some limitations. Whether we can speak to causation is probably not, but we can certainly look at some interesting correlations. And we might at some point want to have a prompt. We haven't done this yet, but we can ask people, what's it been like to write these journal entries? So there are a couple of interesting things happening. We've got people thinking about their journaling as being part of a community. Some folks pick fights with other people, or they get mad at us about something that we posted on the curated site. So at one point we had someone saying that they think that that COVID-19 is a hoax and it's all going to pass after the election. There's a strong, you can imagine the bias. There's a pretty strong centrist to liberal bias among the folks who are participating. But there are some outliers. I think they might be largely among students who are being encouraged. We've got robust recruitment measures in place, but there are faculty who are encouraging students to present. We've got some students who are expressing some of these views. So we posted one of these and someone else got really mad. And we had a little internal conversation about how to handle this. And we said, well, we posted, a skeptic, let's post someone getting pissed at us and see if that plays out in the community. So there's the community kind of piece, and then there's a question of impact on individuals over time. And I think we might want to have a prompt and ask, how's this been, to actually put the question out there. So, some limitations, but there are some things I think we will be able to speak to with the data we have.
Well, unfortunately, we're short on time. So I think we're going to put an end to this. So I'd love to continue the discussion further. I think there's a lot of potential for continued research for all of these projects. I want to thank you again, the presenters and everyone who participated in this panel discussion. We did record it. It's going to be posted on InCHIP's YouTube page. Do not forget to register, as I'm blinking again. Do not forget to register for our upcoming panel discussions. We're also hosting a talk on Monday at 3 p.m. on racism and raising the bar to publish on racial health inequities. We will do it via WebEx, and Dr. Rhea Boyd, Director of Equity and Justice for the California Children's Trust and Chief Medical Officer for San Diego 211, is giving the presentation. It's not about COVID, but it's very appropriate presentation, relevant, and I'd love to see you guys there. So I want to thank you again, and I hope you have a wonderful rest of the week and stay safe.
Thank you. Thanks for hosting this. Bye, everybody.
Bye.